this is kind of cheating because I talk to Mark all the time, but so so from a lot of feedback that I've gotten over the years, clinicians are often at a loss for what to do when patients are sharing very difficult parts of their story and difficult parts of their narrative, and things that cannot be changed, like past traumas or past very stressful experiences. So do you have advice for clinicians on how to deal with that in that moment?
I think as a physio, I have to be careful of recognizing where my scope of practice lies and not trying to delve into counseling people about that type of issue for them. But I do try to plug people into, that's part of you who's now taken that experience forward, and that affects you going forward. It's tough waters to tread because as physios, I think and that's all I can speak for, is it's not comfortable ground for many of us to stand, because it's not how any of us were trained to really look at a patient. It was very much looking at mechanics and movement, and again, not that that's wrong, but it just definitely doesn't encapsulate the complex experience that we see with patients. So when we're getting some of those tough statements and tough, past traumas and things, if something that I can at least plug them into how that affects them, and then I've been blessed to have psychology colleagues and social work colleagues close by where I can help talk to patients about, what, we do know that this type of thing is really helpful if you discuss this with somebody, because this can help, you kind of desensitize your system and get things back down to where you're better able to cope with some of these stressors that you got going on in life. So just being able to recognize when you have some experts in that area to lean on, but at least being able to, as a healthcare person, to not just throw those experiences to the background and not at least help that patient conceptualize that affects them and who they are and how that will affect them perceiving things going forward. Yeah.
Another question right up here.
Thanks, Mark.
Yeah.
I'm curious if you'd be willing to share some of your story of how you moved from tissue-based to caring about the patient story.
Well, I think it's through failure, really, is what really drove me to and again, I don't want to say I'm not tissue-based, because ankles still get sprained, discs still acutely herniate, so there's times where I regress back into tissue-based treatments, and it's not to say, I'm just talking to people about psychosocial factors when they have a sprained ankle, and they pretty much just need me to treat their sprained ankle. But after treating numerous patients and just not getting across, manual therapy did not work. I've worked with some pretty high-level manual therapy clinicians. I can parallel Gifford's experience when he worked with Jeff Maitland in Australia, and Jeff Maitland, amazing manual therapist, and did amazing contributions, but Gifford saw this patients that weren't getting better in his clinic, and I saw patients with amazing guru therapists that I was able to mentor underneath not get better with a strict manual therapy approach. And often those type of factors with a patient were kind of shoved aside, and how do I get to a treatment threshold where I'm going to start wiggling a facet around or manipulating something or whatever it may be for that manual therapist. So it was just recognizing that narrative did not work for patients, and there was obviously more out there. And in my pain science course in fellowship was really where I really said, aha, that made sense, that why these people didn't fit that narrative, because the research, when you're looking at an emotional thing and you're trying to treat, that's really modulated by the emotional and coping mechanisms of a human being, yet we're trying to do it all through mechanical means, you're not pairing the intervention up with the problem. And I think, can you change it though temporarily? I mean, we see all kinds of temporary short-term effects with manual therapy and a lot of peripheral interventions, but in that population sometimes. But what makes long-lasting life changes, I don't think Gilletta would say it had anything to do with the manual therapy technique, and I don't, again, see that approach, again, not being wrong, but it's not necessarily the answer for a lot of those people who are dealing with a lot more complex situation than one we're going to try to reduce to, a facet issue or some sort of biomechanical fault in their back or shoulder or something. Does that answer your question?
We have another question up here in the second row.
Thanks a lot, Mark. That was great. Do you have any suggestions or strategies that work for you to help bring your colleagues along this journey? Because that's really a barrier in my world, doing all this extra work on learning and changing my practice, and then having the patient go next door and get all of the same old same.
Yeah, I wish I had a solution for that one, because you can do the best pain science, education, and really feel like you connect with the patient, and it can be destructed in a 10-minute encounter with a neurosurgeon or a colleague. I've had, a lot of physios who are still very mechanically based, strictly, and that can really, I've had conversations where if I've been referring a patient, I try to be proactive and try to introduce that, this patient is fearful of body structure and different things, where I might try to cue, if I know they're going to go see another colleague, where so I'll try to cue it up to just show, talk about central sensitivity and different things that might be going on in that patient's case to hopefully help that clinician not slide back into. But it's a tough transition. I don't know, many of you guys who've done it here probably can, but to delve out of your comfort zone where it's just resolved to a joint in a manipulative technique, that's a scary place, because it's like your clinical comfort zone, and it's really, it can be tough for clinicians to want to, go to that being uncomfortable, not knowing type scenario, where I think manual therapy gave me this false sense of knowing, and being comfortable not knowing was a big thing for me. But how to get that across to colleagues, I think this kind of thing, and mass media, social media, all these things, and continuing education courses and people pushing this information out, hopefully changes things. I don't know how we can look at statistics of chronic pain and the opioid crisis and all these things and think we're doing good in healthcare with pain. I just think that's ridiculous. So,
Mark, just to piggyback off of that question, there's a lot of different professions represented in this room and also observing online, and some of us are licensed healthcare professionals, but then there's a whole range of complementary professions, from personal trainers and massage therapists and rolfers and structural integrators and blah, 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 right?
yeah.
Now, there's a lot of us are seeing people that are either already working with healthcare professionals or who are not currently because perhaps their insurance cut them off or something like that. And there are times when somebody will come to us saying, my doctor or whoever said, I have this, and it's a very biomechanical thing. And so it is not our place to say, no, you don't. But we need to work with them.
Yeah.
And so I'm wondering if you could speak a little bit to the challenges of facilitating that interdisciplinary conversation so that we can try to connect a little bit more easily, and maybe, and maybe find each other, so that, if I get somebody coming in and say I have a diagnosis, maybe I can refer them for a second opinion to somebody that maybe has a different perspective.
Yeah, so you're saying for to be able to communicate with a physician who's given that information? Or
Physician, PT, whoever.
That's a tough one, because the PT or the physician needs to have the humility to hear you, which sometimes I can speak for myself, sometimes I didn't. But I'll tell you, the personal trainers and massage therapists who are very pain science informed, I think are great resources, and I think I would love to see more in healthcare to help our patients. And get them with a more constructive narrative around their pain and kind of pull them away from some of that stuff. I think you can lead patients to resources and some of the YouTube videos and different things that can help patients maybe reconceptualize those things. Or as Greg said, instead of coming at a patient and being abrasive with what they've been told, saying, okay, yeah, but let's see what we can do and work constructively here, and here. The great thing about that, your degenerative disc, is we know that actually movement and all these things, we have some great research. So using research can be a helpful, powerful tool for people. I know that's maybe not always what is, with the personal training profession and massage, but I think a lot of your physio friends would be happy to arm you with any of that stuff to help patients reconceptualize things, maybe in a more adaptive way of looking at it, as opposed to some of the fear-inducing stuff that we see out there. So it's a tough one. I think we have such a culture of still with the biomedical way of looking at it and those narratives that we give to patients. But I think sometimes, and Gifford says this in his books, it comes a time where you got to stop talking, you got to start doing. So I think sometimes with personal training, for instance, you can confront a person with their strength and show them how much they're able to do. Maybe you use more of a graded approach and a graded exposure way of looking at it, but you can start getting these people to where they start seeing their abilities and you strip the fearful narratives away from them and start moving them forward. But as far as communicating with your physician colleagues and physio colleagues who might be giving them a narrative that's not more helpful, I think you can reach out and hopefully maybe have a conversation that you can see if you can find some common ground with them, or you try to find some like-minded individuals in your community, some PTs or some fellow personal trainers or doctors who might be some good referral sources that you can bounce some ideas off of.
We have a question up here towards the front. Okay. Let's take a question online since she's got the mic.
Yeah, we have a lot of questions, so I think you've answered a couple of them already, but one question that Donna is asking is if you can clearly hear the patient telling you that they are not intrinsically motivated to engage in a process of collaboration, what might you do?
If they're not ready to engage in collaborative approach, you know, there are some times where despite best efforts, despite your best work at educating patients and despite best things, people might not be in a place in their life. I don't just default to that when I hear somebody do that. We'll try to see if we can do some, start showing people instead of trying to talk people into being collaborative. We do some motivational interviewing and different things. I think that's a huge skill that all physical therapists and healthcare people should do. How do you get somebody who's not motivated, is not even thinking about changing their behavior? How do you move them to behavior change where they're going to do something? But that's where you got to structure conversations to have the patient talk themselves into change and not you directing them forcefully into change. And that's as easy as that may sound, which probably doesn't sound that easy, but it is extremely difficult. I've been fortunate to work with Eric Kruger, who's doing his PhD and does a lot of work with ACT, and he's doing his PhD in psychology, where I'm trying to glean better skills of that. That's a skill I think we can all develop, and it's a skill that is constantly in need of refinement. But that would be the number one thing, is can you see if you can structure conversation to where you can start getting people to see why, based on their life, it might be valuable for them to change behavior and then move them forward in that case. But if you're still running into walls, then there's times where I've said to patients, look, this may not be the right time for you, because in the past I would just default back to manual therapy mode and cracking joints and massaging and doing different things that would give them temporary relief, but then 30 visits later, the same pain came through the door, nothing changing in their life, they were the same. And I've just decided now that what I feel the best interest of that patient is not being the 21st therapist to do the same thing over and over again and expecting something different, and maybe saying, hey, this might not be the time for you right now. I'm going to be here. I think we have some great things we can do, but I don't think that's the approach that's best for you now based on X, Y, and Z that we just talked about today. And if you're ready in the future, I'm always going to be here for you. I wish you nothing but the best in your pursuits, and let me know if I can help you again. So that's, I guess, my approach with it.
Let's take another online question, and then we've got a gentleman in the second row in the plaid.
Yeah, so another question we got from the same person, Donna. She kind of, along the same lines, wants to know what professions might we refer to for that patient who may be struggling to become more intrinsically motivated to take ownership over their experience.
Professions you could refer to,
Yeah.
That's psychologists, social workers, folks that, it depends on what we identify might be the barriers in that patient's, taking ownership. I often find that communicating with my physician colleagues, I'm lucky to where I can just walk downstairs and talk to the doctor. I just had a patient the other day who's fibromyalgia. She's angry, she wants to be fixed, and she has just a lot of personal, social, relationship issues going on that really are apparently a big driver of a lot of her sensitivity. And I walked downstairs to my physician colleague and said, hey, this is what I was just told from Mrs. Smith. I really think we need to plug her into psychology and get her kind of engaged, but I don't know if there's a one-size-fits-all who to refer to. I think it's what that patient demonstrates as far as need and where their specific barriers are. But I think if you can find a way to get a unified message, that's why I'm lucky to have kind of an integrated healthcare team where we can all sing the same message to the patient instead of having somebody pulling them back into, biomedical, your tissues are fragile and you're going to, ooze the jelly out of your disc kind of narratives.
Thank you.
Thanks, Mark.
Yeah.
So my question was for, in terms of so you revert back to that, tissue-based stuff for things that are attributable to that. Are there factors that you identify that would lead you to talk about these types of things as well, even in the acute stages of injury? And if so, what are those factors?
You just see how somebody's coping with their situation. I mean, what do you think's going on? I mean, you have patients where you can visibly see. I mean, you get the ankle sprain patient who's like in a wheelchair where mom's wheeling the kiddo into the room and won't bear weight, won't let things be touched, and where you just see this, you can just see this pretty significant reaction to what doesn't seem like it should be if we just look at it mechanically, what went on. So those are some of the things we can see, but just talking to the patient and hearing fear and what do you think's going on with this? What do you think you need to get better? Why do you think you hurt? And you just get some of these things that start coming out with these acute pain patients like, whoa, this is, not a very adaptive view of things. We need to start, doing the standard things we do to help tissues heal, but that's where I engender confidence. Like, the swelling you have is awesome. That's your body doing its, appropriate things where we, really point out the positives with the patient instead of doing what we used to do is just, here's your problem list, patients, of all these faults I found in you, and these are all the things we need to correct. And I mean, again, that just steers people further into the wrong direction. So trying to, instead of a problem list, maybe make a positive list of all the things that you can find good with that patient that are going well, and then again, just positive reassurance, getting them moving, really making sure you educate them about tissue healing and how the body's designed to do that, and all the good things we know that the human body's capable of doing, and not, again, pulling them into that narrative that, to me, steals their self-efficacy when we're telling them that they're damaged goods and broken beings.
We're going to take one or two more questions from our online participants. Or is...
Yep. So we have one more question, and that is, how do you handle the fatigue that often accompanies chronic pain?
How do, like, the fatigue as a clinician or the fatigue as a patient?
I'm not 100% sure. Maybe both.
As a patient, I mean, there's a lot of things, activity pacing principles and different things we can do. Understanding, when we're dealing with conditions such as chronic fatigue syndrome, they're kind of neuroendocrine immune wired a little bit differently to where things, they don't have a good ability to, get into that arousal phase of the endocrine system and do, or sometimes they're tapped out. I mean, obviously there's a lot of complexity that can go into fatigue, but teaching people, that actually getting into exercise and being active, and there's some decent research with chronic fatigue syndrome, some trials that if we get people engaged in exercise, that can help. Now, obviously, it needs to be something that isn't like going to a trip to the dentist for the patient, trying to find something that brings them some enjoyment that can maybe help tap into some descendant modulation with their, top-down abilities of their nervous system to help out with things. But trying to get them active and showing that it's safe to be active, and that usually the narrative around them has not been active, and they've, when they can see that they've, inactivity and deconditioning and all the things that spiral into that cycle, hasn't been changing things the way they've been hoping to, that maybe there's an alternative path for them. But again, not just forcing that narrative upon them, trying to construct a conversation where you're having them, help them come to that conclusion on their own, can be huge.
Great, thank you.
Yep.
All right, I know there were more questions. I saw